let's assume the claim successfully makes it through adjudication, either right away or maybe after a successful appeal. How does the provider actually receive the money?
If the claim is approved, the insurance company sends reimbursement directly to the provider. Now, the amount they pay is determined by two main things: the patient's specific plan benefits, like their deductible and coinsurance, and critically, the provider's contract with that specific insurance payer.
Ah, the contract.
Yes, these contracts include a negotiated fee schedule, which dictates the maximum amount the payer will allow for each specific service code, CPT or HCPCS.
So let's say a provider lists a service at, I don't know, $200 on their internal price list. But if their contract with Blue Cross only allows $150 for that code, then $150 is the most they can expect to get from Blue Cross for that service, for that patient.
Exactly right. That $150 is the allowed amount. The difference between the billed amount, $200, and the allowed amount, $150, is what's called a contractual adjustment or contractual write-off. It's a standard part of the process based on the pre-negotiated agreement between the provider and the payer.
So providers don't usually expect to get their full listed price from insurance.
Generally not from contracted payers, no. The allowed amount is key. And the source also points out a really significant shift happening in how providers are paid. We're moving away from the traditional fee-for-service FFS model.
Where you just get paid for doing stuff.
Right, paid based purely on the volume of services rendered. The more you do, the more you bill. We're moving towards value-based reimbursement, or VBR.
Value-based reimbursement, that sounds different. How does that work?
It is different. VBR models tie at least a portion of the provider's reimbursement to the quality of care provided and the patient's health outcomes, not just the quantity of services.
Interesting.
This is a major trend being pushed by payers like Medicare and many private insurers, trying to incentivize better health outcomes and efficiency, not just more tests and procedures.
How does that impact the billing side of things then?
It means billing isn't just about getting the right codes and charges onto a claim anymore. It increasingly involves collecting and reporting data on quality metrics, things like controlling blood pressure for hypertensive patients, patient satisfaction scores, hospital readmission rates, overall health outcomes.
So billers need to track more than just money.
Exactly. Providers are incentivized financially for keeping patients healthy and managing chronic conditions effectively. Billing systems and the billers themselves need to be able to track this performance data and submit it correctly to the payers to qualify for potential bonuses or avoid penalties tied to these VBR programs. It adds another layer of complexity.
Okay, so payment eventually comes in, based on either FFS or VBR models. How does the provider know exactly what was paid, for which patient, for which service, and maybe why something wasn't paid?
Payers send detailed explanations along with the payments. Commercial payers usually send an explanation of benefits, or EOB. You've probably received these yourself.
Yes, the ones that look incredibly confusing sometimes.
They can be, but the EOB is designed to break it down. It's a document explaining which services were billed, the amount charged by the provider, the allowed amount according to the contract, how much the insurance company actually paid, and crucially, how much, if any, is now the patient's responsibility. EOBs often go to both the patient and the provider.
Got it. So that breaks down all the numbers for a specific claim.
Right. And for the provider, especially when they receive payments electronically, they get what's called a remittance advice, or RA. Often this comes electronically as an EDI 835 file, which is also known as an ERA electronic remittance advice. The ERA, or RA, is similar in content to an EOB, but is specifically formatted for the provider's billing system. It usually covers a whole batch of claims paid at once, detailing the payments, any adjustments, like those contractual write-offs, and any denials from multiple patients all in one file. Using ERAs for payment posting is far, far more efficient than manually typing in data from paper EOBs.
Makes sense. So the ERA tells the provider exactly what was paid for every claim in that batch. Looking at that, or the EOB, there's often a part left over for the patient to pay, right? That patient responsibility piece.
Yes, absolutely. That's the patient financial responsibility. After the insurance company has processed the claim and paid its portion based on the allowed amount and the patient's specific benefits, there's often a remaining balance the patient owes directly to the provider. The source outlines the common components of this balance.
Right, the familiar terms: copays, deductibles, and coinsurance. Everyone hears these, but they interact in a specific way that determines the final bill.
They do, and it's important to understand how they work together. A copay is typically a fixed amount paid by the patient at the time of service, like a $20 or $50 copay for a standard doctor's visit. pretty straightforward.
Okay.
The deductible is the amount the patient must pay out of pocket each year for covered services before their insurance plan starts contributing significantly to the cost. Think of it as the initial hurdle.
Got it. You have to meet that first.
Right. Once the annual deductible is met, then coinsurance usually kicks in for many services. Coinsurance is a percentage of the allowed amount for covered services that the patient is responsible for paying, with the insurance company paying the remaining percentage. Like an 80-20 split is common. Insurance pays 80%, patient pays 20%.
Let's use that calculation example from the source because it really clarifies how these work together. Say a patient has a $1,000 deductible and 20% coinsurance. They have a procedure that has an allowed amount of $5,000. How does that play out for the patient's bill?
Okay, good example. Step 1. Has the patient met their deductible yet this year? Let's assume no. They still have the full $1,000 deductible remaining. So they pay the first $1,000 of that $5,000 allowed amount themselves.
Okay, deductible met now.
Deductible is now met for the year. The remaining portion of the allowed amount for this procedure is $5,000 minus the $1,000 deductible, which leaves $4,000.
Got it. So now coinsurance applies to that remaining $4,000.
Correct. Their coinsurance is 20%. So the patient is responsible for 20% of that $4,000, which is $800. The insurance company pays the remaining 80% of that $4,000, which is $3,200.
So for that $5,000 procedure, the patient's total out-of-pocket cost is the $1,000 deductible plus the $800 coinsurance, totaling $1,800. And the insurance pays the remaining $3,200. That example really makes it concrete.
It does. It highlights how those different benefit types, deductible and coinsurance, combine to determine the patient's final bill after insurance pays. The source also mentions out-of-pocket maximum.
Right, the safety net.
Kind of, yeah. It's a limit on the total amount a patient has to pay for covered services in a plan year, including deductibles, co-pays, and coinsurance. Once that maximum is reached, the insurance typically pays 100% of covered services for the rest of that year. And of course, patients are also responsible for any services their plan simply doesn't cover at all.
What if a patient has coverage through two different insurance plans? Like maybe through their job and also through their spouse's job. How does that work?
Yeah, that involves coordination of benefits, or COB. This is the process payers use to determine which insurance plan pays first, that's the primary plan, and which one pays second, the secondary plan.
So they don't both pay the full amount?
No, definitely not. The primary payer processes the claim first according to his rules and benefits. Then, whatever balance remains up to the secondary plan's allowed amount for that service can be submitted to the secondary payer. The source gives a common example for determining primary for dependent children, the birthday rule.
The birthday rule.
Yeah, generally the plan of the parent whose birthday falls earlier in the calendar year is considered primary for the child's claims. There are exceptions, but that's a common default rule.
Interesting detail. Okay, so the insurance company pays their portion, or primary and secondary pay theirs, and the patient knows what they owe. How does the provider's office actually keep track of all these payments coming in?
That's handled through a process called payment posting and reconciliation. Once payment is received, whether it's from an insurance company via an ERA or check, or directly from a patient, it must be accurately recorded or posted to the correct patient's account in the billing system.
Linking the payment to the specific service and patient.
Precisely. This can be done manually by reading a paper EOB or check stub and keying in the details, but far more commonly and efficiently now, it's done electronically by importing the data directly from an electronic remittance advice, ERA or EDI 835 file, into the PMS.
So payment posting isn't just about recording the cash received. It includes posting other adjustments too, like that contractual write-off.
Absolutely. When you post a payment, you're posting the actual payment amount received, but you also need to account for different types of adjustments. The source defines things like contractual adjustments. That's the standard write-off between the provider's billed amount and the payer's allowed amount based on their contract.
Yeah.
There can also be other types of write-offs, like deciding to write off a small balance as bad debt if it's deemed uncollectible from the patient after multiple attempts, or maybe a timely filing write-off if the practice missed the deadline to submit the claim to the payer, which they try hard to avoid. And sometimes refunds are necessary and need to be posted, like if a patient or even a payer accidentally overpaid an account.
Lots of pieces to track.
Yeah.
And reconciliation. What's that?
Reconciliation is the crucial step of balancing the books, basically. It's the process of comparing the total payments posted in the billing system against the expected revenue based on the ERAs or EOBs received, and also comparing it to the actual deposits made into the practice's bank account.
Making sure everything matches up.
Exactly. It's about finding and investigating any discrepancies. Maybe a payment amount posted doesn't match the expected allowed amount from the contract rate, or maybe a payment listed on the ERA hasn't actually shown up in the bank yet. This step is absolutely vital for ensuring financial accuracy and identifying potential problems quickly, like payment processing errors by the payer or even internal posting mistakes.
So the insurance payments are posted and reconciled. Then comes the final step, right? Getting the patient's portion of the bill paid.
Right, patient collections. After insurance has paid and the patient responsibility amount is clear, the provider's office typically sends statements to the patient detailing their remaining balance that could be their copay if it wasn't collected up front of the visit, their unmet deductible amount, their coinsurance percentage, or the cost of any non-covered services.
Sending out the bills.
Yeah. The source discusses using structured billing cycles, like sending statements monthly, to handle this consistently. Best practices really emphasize trying to collect known amounts, like copays, right at the time of service whenever possible, because collecting balances after the patient has left the office can be more challenging and costly.
Makes sense. What about larger balances?
For larger patient balances, offering payment plans is often a recommended strategy.
The source even gives some steps for how to set up a fair payment plan.
Yes, it's about establishing clear terms up front, maybe assessing the patient's ability to pay without causing hardship, agreeing on a reasonable monthly payment amount and the duration of the plan, getting a formal written agreement signed by both the patient and the practice, and then consistently monitoring those payments. It helps the practice recover revenue over time while making the patient's financial responsibility more manageable for them.
Wow, okay. That's a really detailed journey from the initial service all the way through to final payment. And even within all that, the source dives into some deeper complexities, like the use of modifiers. You mentioned those briefly.
Oh, yes, modifiers are fascinating and crucial. They are these little two-character codes, alphanumeric, or just numbers that get added on to the end of a CPT or HCPCS code.
Just two characters.
Just two. But they provide critical additional information or context about the service performed. They don't change the basic meaning of the primary code, but they clarify how, where, or why it was performed under specific circumstances.
Why are these little two-character codes so important? How much difference can they make?
They dramatically impact how a claim is processed and ultimately whether it gets paid correctly or paid at all. They tell the payer important details like, was the procedure performed on the left side or the right side of the body? Modifiers like NERT and NELT handle that. Or negative 50 indicates it was bilateral, done on both sides. Or maybe an evaluation and management visit, like a checkup, occurred on the same day as a minor procedure. Modifier negative 25 tells the payer the visit was significant and separately identifiable from the procedure. Or modifier negative 59 might be used to indicate that one procedure was distinct or independent from another service performed on the same day, maybe at a different anatomical site or different session.
So they prevent the payer from thinking things are duplicated or bundled incorrectly.
Exactly. They clarify the situation. The source provides an example where simply using an incorrect modifier or forgetting to use one when it was needed led directly to a claim denial.
So adding or omitting just two characters can literally be the difference between getting paid hundreds or thousands of dollars and getting nothing. That requires incredible attention to detail.
It absolutely requires precision and a deep understanding of not just the codes themselves, but also the specific rules each payer has about how they want modifiers used. It's a common area for errors and denials.
And the field keeps evolving, right? The source touches on billing for newer ways of delivering healthcare, like telemedicine. That must have its own wrinkles.
Oh, definitely. Telemedicine billing is a prime example of how billing has had to adapt quickly, especially recently. It involves using specific CPT codes designed for different types of virtual visits, like synchronous visits using live audio-video.
Like a video call with a doctor.
Exactly. Or asynchronous visits, which involve collecting and interpreting stored information, like reviewing images or monitoring data sent by the patient later. There are even codes for audio-only phone calls in some cases. And specific modifiers, like negative 95, are often used to signify that a service was delivered via synchronous telehealth.
Is it straightforward now?
It's getting better, but billing for telemedicine can still be a bit tricky because payer rules and reimbursement rates for these services can still vary quite a bit between different insurance companies and even different states for Medicaid. It's an area that's still settling.
Are there other special circumstances that have really unique billing rules?
Yes, the source mentions a couple of important ones: workers' compensation claims and auto insurance claims.
For work injuries or car accidents?
Right. These are generally handled very differently than standard health insurance claims. They often have completely unique forms, separate fee schedules dictating what they'll pay for services, which might be higher or lower than health insurance rates, and distinct processes for claim submission, documentation requirements, and payment. Billers dealing with these need specialized knowledge.
So it's not one size fits all.
Not at all. And the source also briefly touches on the No Surprises Act. That's a relatively recent federal law aimed at protecting patients from getting those unexpected, often large, balance bills from out-of-network providers, particularly in emergency situations or when they receive care at an in-network facility but are unknowingly treated by an out-of-network doctor, like an anesthesiologist or radiologist. It adds another layer of rules about disclosure and dispute resolution.
This all just points back to the absolute need for robust internal processes to avoid costly mistakes and potential legal or compliance issues.
Exactly right. That's why having a strong, formal compliance program is really essential for healthcare providers of all sizes. The source outlines elements of an effective program, often based on guidelines from the OIG, Office of Inspector General.
What does that involve?
It typically includes things like having written policies and procedures covering billing rules and regulations, conducting regular staff training on compliance topics like HIPAA and FWA prevention, performing ongoing internal monitoring and audits of billing practices, and having a clear mechanism for employees to report potential compliance concerns without fear of retaliation.
Like an internal watchdog system. Speaking of audits, providers face those from the payers too, right? Insurance companies checking up on them.
Oh, they do. Payers routinely conduct audits. Sometimes they happen before paying a claim that's called a pre-payment review, where they might request documentation before releasing funds. More commonly, though, audits happen after payment has already been made.
Looking back at old claims?
Yes, a post-payment audit. They'll request medical records for a selection of claims, sometimes going back a year or more, to review the documentation and verify that the services billed were actually provided, correctly coded, and medically necessary according to their policies. If they find errors, they can demand repayment, sometimes with interest or penalties. These are called recoupment requests or takebacks.
Ouch. So that puts pressure on providers to keep good records.
Immense pressure. And it's why providers also benefit greatly from conducting their own internal audits or sometimes hiring external auditors to do mock audits. These help identify potential compliance risks or billing errors before an external payer audit finds them. It allows them to correct processes and educate staff proactively.
So internal audits help catch problems early and prepare for the inevitable external ones. Looking ahead now, what's on the horizon for medical billing? Where is this field heading?
The source highlights a few key trends shaping the future. One is the increasing adoption of artificial intelligence, AI, and automation.
The robots are coming for billing.
Not quite taking over, but definitely assisting. Technology is being used more and more for tasks like automated claim scrubbing, catching errors, even before the clearinghouse, perhaps. AI can help predict and identify potential coding or billing errors based on patterns. It can assist coders by suggesting relevant codes based on clinical documentation, and it can automate repetitive, data entry-heavy tasks like payment posting from ERAs.
So computers taking over some of the heavy lifting, freeing up humans.
That's the goal, yes. Improving efficiency, reducing those costly manual errors, and allowing skilled billers and coders to focus on the more complex judgment-based tasks like handling difficult denials, navigating complex appeals, and managing those value-based care requirements.
Which is another trend you mentioned.
Exactly. That continued shift to value-based care that we discussed earlier is a major driver of change. As reimbursement becomes more tied to quality metrics and patient outcomes, billing systems and workflows will need to become increasingly sophisticated. They'll need to capture, track, and report on all that quality and outcome data required by VBR models, in addition to the traditional fee-for-service volume data. It's a big shift in focus.
More data integration.
Much more. And finally, the source mentions the ongoing strategic decision healthcare practices constantly face regarding outsourcing their billing operations versus keeping it all in-house.
To hire a billing company or do it themselves.
Right. It's a common business consideration. Outsourcing to a specialized medical billing company can provide access to deeper expertise, more advanced technology platforms, and potentially economies of scale, which can be particularly attractive for smaller practices that can't afford their own dedicated, highly trained staff and software.
But there are downsides.
Sure. Keeping billing in-house offers more direct control over the entire process, the data, and maybe more seamless patient interactions regarding billing questions. But it requires significant ongoing investment in staff training, keeping up with technology, managing the process effectively, and staying current with all the rule changes. Both models have pros and cons, and the right choice really depends heavily on the specific practice's size, specialty, complexity, and available resources.
Wow. Okay. We have really navigated the entire complex financial journey of a patient encounter. From that initial registration and insurance check, through the critical steps of coding and charge entry, building and submitting the claim, often via clearinghouse,
Then waiting for the pair's adjudication.
dealing with the possibility of rejections and denials, and the whole appeal process,
Hmm.
understanding how insurance actually calculates payments based on contracts and benefits,
Posting those payments and adjustments accurately.
figuring out the patient's responsibility, copays, deductibles, coinsurance, and then the collections process.
And we even looked at deeper complexities like modifier usage, special scenarios like telemedicine and workers' comp, the importance of compliance and audits.
And glance towards the future with AI, value-based care, and the in-house versus outsourcing decision. It's a lot.
Yeah, it really is. It's a field that truly underpins the entire healthcare industry's financial stability. Understanding even the basics of it is incredibly valuable, whether you're trying to make sense of your own medical bills, maybe considering a career in healthcare administration, or frankly, just wanting to comprehend how the financial engine of this massive vital sector actually operates day to day.
It clearly demands incredible attention to detail.
Absolutely. Precision, persistence, and just constant learning because the rules are always changing.
It certainly seems that way. And as we wrap up this deep dive, maybe here's a final thought to leave you with. This complex world of medical billing seems to be constantly grappling with a fundamental tension. On one hand, you have the critical need for healthcare providers to be paid accurately and efficiently for the essential services they need to keep the lights on.
Mhm.
But on the other hand, there's the societal goal and the patient need for a healthcare system that is affordable, accessible, and transparent. How will the ongoing technological advancements like AI and that continuing shift towards valuing outcomes over just the volume of services continue to reshape that fundamental tension in the years ahead? How do we balance paying providers fairly with keeping care affordable and understandable for patients?
That's the multi-billion-dollar question, isn't it? And something the industry will continue to wrestle with.